we've just last November, conducted the world's 8th International Scientific Conference on Friedreich's ataxia, and that involved about 450 scientists instead of 0 drug companies at that first one. They all said, you're too rare, you're on your own. We now have more than 4 dozen scientists, 4 dozen industry partners. They're not only coming to our international conferences, they're helping us fund those international conferences, and instead of 0 clinical trials, by the time we did our 8th international conference, we'd already conducted more than a dozen clinical trials and completed them. We had another dozen underway, and some of those clinical trials included what would be profoundly beneficial to us, protein replacement program that's in clinical trial now, 2 gene therapy programs, both for heart, and about a dozen gene therapy companies interested in conducting clinical trials in our disease.
So we're going to talk a little bit more about how there are 3 main aspects to what financing looks like, regardless of who the payer is. The first being that access is complex. The second being more about that these roadblocks that exist, regardless of payer, exist for a variety of reasons. Depending on your vantage point, it is a way to make sure that a drug is provided and it is being used clinically in a clinically appropriate way. Or it is an impediment to someone receiving care, and it is very annoying. Or oftentimes life-threatening if it is delayed too long. So there are perspectives to this that create some of this additional uncertainty when it comes to how payment is determined and when payment applies. There's also an element that I think is really important, and this is where I'll dive into a little bit more of the financing models and, that we've seen today, that there's a desire to finance at scale. When someone has a rare disease, there's this desire to say, okay, we know it's a rare disease, now we can pay for it. That doesn't exist. There are an innumerable number of models. I will try to outline about 7 of them very quickly.
We've talked about it earlier, but I just want to make sure everybody understands. This was an FDA mandate that was driven to try and increase access to these drugs in the marketplace. There were tax credits for qualified clinical trials, exemptions from user fees, but most importantly, the potential for 7 years of market exclusivity after approval. So once that exclusivity expires, the incentive to be able to produce that drug drops off dramatically. This is where the problem that we're going to be faced with all these drugs that were part of this program are going to end up. So we need to come up with a plan for that. And of the 503 drugs that have received orphan status, 217 are no longer protected, and only 116 of these currently face generic competitors. So what's happened is when you have exclusivity, you basically have a monopoly on that market, and you can charge what you can afford to charge. So the question is, how do you start to create a level playing field?